only mode.
Hello everyone, and welcome to the Colorado MESA Initiative First Friday webinar. This is Holly LeMaster. I'm the program coordinator, and today we're going to be talking about how to have important end-of-life discussions with your patients and their family members. Just a few housekeeping items before we get started. I just want to mention that you'll see your GoToWebinar control panel in the upper left corner of your screen. If it's bothering you or it's covering your slides, you can minimize it using the little orange arrow button. And there are a couple of options for audio. You should be able to hear us using your computer speakers, and you might want to adjust the volume to be sure that you can hear us well. As an option, if you're not able to hear over your computer or if you don't have speakers, you can dial in over the telephone, and in your email that you received, your confirmation email about the webinar, there is your dial-in phone number, your access code, and the webinar ID that you're going to need to log in over the telephone. All of you out in the audience are muted. If you would like to ask questions, you can type them into the question panel on your control panel, and you can see that here on this slide. And we'll be taking your questions and answering them at the end of the webinar. Just want to remind you that handouts for these webinars are always available on our website, which is www.coloradomesa.org. You'll need to sign in, and you want to go to the events section and look for the upcoming webinars, and you'll see the handouts for today's webinar. By next Monday, we'll have the archive of this webinar posted, so if you want to watch it again or if you want to share it with your colleagues, you can do that. On Monday, you'll find it under the archived webinar section in the classroom. So our speakers for today are Dr. Donald Murphy. He is one of the founders of the Colorado MESA Initiative and one of our faculty members. He graduated from Notre Dame and the University of Colorado School of Medicine and did his geriatric fellowship at Harvard. He was one of the founders of the Senior Care of Colorado Geriatric Practice back in 2001, and now is the practice group leader. There are almost 70 providers in this practice, physicians, nurse practitioners, physician assistants, licensed clinical social workers, one of whom will grace us with his presence today, with 7 outpatient clinics and almost 100% Medicare. Mark Grimm is a behavioral health expert in the field of geriatrics. He graduated from the University of Indiana and has his master's in social work from the University of Denver. He's practiced as a social worker since 1984 and with the Senior Care of Colorado practice for about 2.5 years now. He works today exclusively with seniors in the behavioral health area. So Dr. Murphy and Mark, welcome to the webinar.
Thanks, Holly.
Take it away, Dr. Murphy.
Hi, everyone. I just want to remind folks about the Colorado MESA Initiative. It stands for Medicare Experts Senior Access. Our goal really is to help improve access to good quality of care for seniors throughout the state. We want you to be adept at Medicare coding and documentation, make sure that you're paid fairly for your work, and also to be comfortable serving patients with dementia and other geriatric syndromes. This is a collaboration funded by the Colorado Health Foundation, the Kaiser Permanente Foundation, and Caring for Colorado. We work closely with the Alzheimer's Association, the Colorado chapter, and as Holly mentioned, our faculty members come from our practice, Senior Care Colorado IPC.
Okay, I'd like to review for the group today what we plan on covering. So we're going to basically be talking about patients and family members being sensitive and having an open forum to discuss issues related to death and dying. And under that first bullet, you notice we need to talk about the challenge for providers, since we're a very key aspect of this whole process. We're also going to be talking about some general guidelines about how to have what I just generally call the talk, which will involve attitudes related to grieving and dying. We'll also be talking about some of the medical interventions that family and our patients will need to talk about to guide us in making our clinical decisions. There are also some tools and resources that can help all of us guide that discussion in an appropriate direction. And finally, we'll be talking about reimbursement for providing these services. I'd like to start by just making some comments. During my 40 years of practice, I am constantly amazed at people's ability to ignore the fact that we're all going to die sometimes. We are born, we live, we die. That's the natural course of things. And as I talk with patients and families, I often get this idea that they expect people to go on and on and on forever. And I do think in our society we have something that I would just call the denial of death, which I think is a great disservice to everybody, because as we begin to grapple with some of these questions about whether or not to treat patients aggressively or not, we may be on different pages, and so consequently time and resources and energies are often misspent. So my first recommendation is it's best to introduce what I call the talk early on, and to also revisit that when we feel that there is a significant status change in the person's condition and also prognosis.
The providers do have to recognize some of the challenges in addressing these issues. First, it can be easy to overlook because the issues may not be imminent. So it's one of those things like discussing vaccines or whatever else we do in primary care where we can always think, we'll get to it later. And there may not be a later. So we do have to have it on the radar screen. Providers and patients can sometimes feel uncomfortable with these topics, but I would argue, as I will later, that when you really get practice at this, there's no need to feel uncomfortable, whether you're a patient or a provider. The family dynamics can be complicated in some cases, but for the most part, people really appreciate that, and you don't see a lot of drama around this. You do have to make the time for it. I'm going to suggest later that depending on how you approach it, it can be very time efficient, but you do have to carve out some time, and as we'll remind you a little later, you want to get reimbursed for that time you spend counseling your patients. So Mark, how do you approach talking with patients and their family members?
Well, the first thing that I like to pay attention to is our own attitudes, because all of us are in different places at different times with all of this. And I'll give you an example of this. I find that sometimes primary care providers see their goal as sustaining life, curing disease states, when in reality oftentimes we're having to assist people with deciding when no longer to pursue treatment. So I think it's important to realize that we're not only treating people while they're alive, but we're also helping them to exit this life when that seems to be imminent or appropriate. Another thing that we've got to keep in mind there's a lot of cultural, religious, ethnic, intellectual attitudes that create a world of difference, and I think we need to be tuned into that. And one of the primary principles of social work, which I think comes into play here, is always starting where the patient is. So we need to be clear on where they're at and then start from there. I run into this situation a lot where patients will tell me, I went in to see this specialist, and they all of a sudden just dump this on me that I'm going to die. And as a result, they stop listening, and then the conversation stops at that point. So again, it's important to keep an open mind, ask questions, understand where they're coming from, and then proceed from there. Another thing is just learning to be straight with people. I had an instance the other day, or in fact yesterday, where a person went to a neurologist and was told that there was some abnormalities on an MRI scan, and obviously this person is suffering from dementia, and the way it was handled is that the neurologist handed the patient and the family a box of Exelon patches and just sort of dismissed them. And they were quite put off by that. So I think, again, the bedside manner is so important, and tuning in that we're all human beings and we all have certain needs, and again, learning to have that relationship established. You're going to be much more effective in these discussions when you've already established what I would call a therapeutic relationship. That opens up the trust and the openness where we're going to be able to engage in a good dialogue. Also, another thing I notice is that, and I do a lot of translating with patients about what their medical condition is like, and they get a lot of technical information which goes right over their head, and so we've got to bring down the terms to a layman's level so they can grasp those and process what it is that we're trying to talk about. Okay, first off, as I've worked with older adults and their families over the years, one of the things I've noticed is older adults really, for the most part, are not afraid of death. What they're afraid of is what's going to happen between now and then. Am I going to be in pain? Am I going to be dependent? Am I going to be completely non-functional? How will people respond to me when I'm in this situation? And, a lot of times people have this idea that they're going to have this ideal death where they're going to go to sleep one night and not wake up, or they're going to have this massive heart attack or CVA and then it's lights out, when in reality we know that medical science has provided us with two realities. One is that we're guaranteed many more healthy years, but we're also being guaranteed many more unhealthy years. And this is a reality that I like to talk about with patients and their family members. And one of the things I also notice is that older adults will test you. They'll drop comments or make statements to you, and what they're really doing is trying to see if you're comfortable with this topic. And when I detect that they're testing me, then that's when I figure out, okay, the timing is perfect now for me to engage in this discussion and to really open up this whole topic. Let's talk about the family dynamics a little bit. When there's a lack of information, family members are just kind of left on their own to make crucial decisions. And I'm always amazed at the disconnect sometimes between what the reality of the person's medical situation is and what the family's expectations are. And so, we need to have some exploration with the family as well as the patient about their values and their desires, and also be aware of the conflicts and power struggles that go on between family members. I'll give you an example of this. Obviously, when we have a family, everybody plays different roles, and sometimes we'll have a family member who has become very, very dependent on their parent. And so consequently, when they're facing the imminent death of their family member, they hold on even tighter because they cannot begin to grasp their life without their parent being present, when another family member might be ready to have them go because they are suffering and the family member is suffering right along with them. And, grief can be delayed if we are not discussing this issue. And I'll talk about grief in just a few minutes, but I find that, it's important to support that grief process and assist people in processing that as time goes on. Okay, having the talk. Let's talk about this a little bit. As I said earlier, aging people, ill, disabled individuals want to have this talk. And, and I'll say to them sometimes, well, I understand where you're coming from. You don't want to live in a vegetative state, or you don't want to have a tube in, or you don't want to have a feeding tube in. Have you had this discussion with your family? And you would be surprised how many times they will respond with, no, I have not talked to them about that. And I say, why not? Well, I don't want to upset them. They don't want to hear it. And so I always try to operate from the point of view that we need to reassure people that, death is normal. And, one of the things I'll say to people is there's a lot worse things in this world than dying. Suffering and not having a good quality of life is worse. And most times people agree with me on that point.
Mark, let me just add, when we kind of go into the talk, I can imagine, well, I know that a lot of clinicians may think, oh boy, we've opened up Pandora's box here. It has to happen, but this could be very involved, particularly when you start to give them more time, listen about their attitudes about death and dying and all that. I would just like to emphasize here, sometimes what we need to do is just understand that this is an issue that needs to be addressed, but we're not going to have the time as primary care docs to do it right then.
Right.
Put it on the radar screen, get back to it, but at least have identified that this is important, we need to pick up on later.
Yeah, and I want to go back to what I said a little bit earlier. Timing is critical. As I work in the area of psychotherapy, you in your own mind may say, okay, this is an agenda item I've got to address, but if they're not ready to hear that just yet, it's going to fall on deaf ears. So I'm very much tuned into this issue of timing, and people will usually let you know in an indirect way when it's time to have that talk. Again, maintaining a dialogue, a back and forth. Again, what I'll ask people is, and I'll start to explore with them, under what conditions do you want to stay alive? What means quality of life to you? And wishes may change. I see a lot of times where people were very adamant that they were going to pursue a particular treatment, and then later on they may change their mind because of they began to understand the reality a little bit more, perhaps. And one of the major social work principles that I abide by is working with the system, understanding what the social support system is. And these obviously are family and friends, as well as physicians, caregivers, clergymen, attorneys. I always try and listen to who is actively involved with this individual, and then I try to draw them into that discussion.
And I would also add that we as the primary care providers often rely on our colleagues to help move this along as well. So whether they're ending up in a nursing home and the social worker at a nursing home is addressing advanced directives for the first time, we can refer to you. You could even refer to the Alzheimer's Association. I mean, they'll help cover these issues if we don't have time to really do an adequate job. So we do need to rely on all of our colleagues to make sure this gets done.
Yeah, it's definitely a team process. I think that works the best. Let's spend a little bit of time talking about grief. Obviously, older adults experience grief. And I think it's important to differentiate between depression and grief. Depression, let me just explain how I define grief. Grief is a natural, normal process that we all go through at various times in our life, and it is a collection of very intense emotional reactions: anger, fear, guilt, sadness, and these are often layered one on top of the other. And so one of the things I know as I do grief education with people, it's important to normalize that grief is a normal human reaction. And this differs from depression, and the way that I will look at this when I'm doing an assessment is to look for vegetative signs, things like sleep disturbance, appetite loss, lack of energy. And I might also add, just as an aside, when I detect that somebody is involved in a grief reaction, I tend to stay away from recommending antidepressant medicines. I find that we need to allow the grief to evolve and to attend to that process, and I often find that the antidepressants are not particularly effective when we're dealing with a normal grief reaction. So there are two types of grief in my mind. Let me just cover these real quick. The first type of a grief reaction is the one that I think that all of us identify first, and this is something that we call normal survivor grief. And this is the type of a grief where somebody dies suddenly or abruptly without any warning, and then a person is thrown into an acute grieving process that basically plays out over the course of about 25 months or so. And this is a type of a grief reaction that gets better with time. Now, I think that the grief that we deal with most commonly in our setting is something called anticipatory grief. And this is a type of a grieving that tends to get worse with time. And initially, there's a lot of denial that something's changing here, and a good example of this might be with Alzheimer's disease, where a family member kind of notices that there's something different, but they deny it or avoid it, and then as time goes on, they begin to realize that this is in fact a dementia process that's going to get worse with time, And I've seen many caregivers who've been in grief reactions, chronic grief reactions that last 10, 15 years or so. And I think we have to attend to the fact that the caregivers will make a subtle shift from going from normal grief into a clinical depression. And we know that caregivers are very prone to depressive reaction. Letting go. I think that one of the things that keeps our patients holding on is that they don't want to let go of their family members. I'll give you a good example of this. I've worked in hospice for about 30 some odd years at this point, and I can tell you a number of instances where people hang on and hang on and hang on, and the family is all around the bed, and they just won't die, and then the family goes home to take a shower, and the person immediately dies. And one of the things that I will coach families about is giving their loved one permission to go, to let them know that it's okay, everything is going to be taken care of, they will take care of each other, they'll survive, and that can be a great gift that a family member can give to a dying person. Obviously, another question that I think is critical is balancing this quantity versus quality of life. And obviously, you know, in my practice over the years, I focus more on the quality of life. And one of the ways that I'll get at this with patients in my interview, I'll just ask them, do you ever feel that life isn't worth living anymore? And that usually opens up a discussion about under what conditions they want to stay around, when they, you know, under what conditions they would choose to live. And I think we also have to talk to people about the fact that just because medical technology exists, that doesn't mean that we're obligated to use it. And I think sometimes people don't realize the consequences of choosing an aggressive treatment course. And I'm sure many of you have had this experience where patients will say to you, you know, if I knew that this treatment was going to result in these types of problems or results, I would never have done this. So there's not necessarily an imperative to use treatment or imaging. That's another one I see. Let's get another CT scan. Let's get another MRI. And one of the things I will often say to them is, well, why? I mean, it's going to basically tell us what we already know. It's not going to really translate into any additional treatment. And that starts the thought process for the patient and the family a little bit more. I think that aids them.
Okay, Mark, what I'd like to do now is note that when you or we or any of us have the time to really delve in, that's great. But I want to offer some very practical suggestions on how we as providers can at least cover some basics. And let me just put this in the framework of our practice, where we may address key advanced directive things as a new patient if we have the time. We may do it on a yearly basis if we're trying to catch up on whether it's the annual wellness visit or what we call PQRI. This is one of the criteria we're looking at. Or there may be those situations where, because of changing conditions, we really need to dive deeper. But the way I do it in kind of a routine way is I tell the patients that I want to focus on 3 different scenarios, and that when I know, or their loved ones know, how they view these 3 different scenarios, we have a pretty good sense of what to do no matter what might come up. That this really is a good patient preference profile, that we don't have to have excruciating detail about all kinds of contingencies, and that understanding these 3 things right here is very, very helpful. So let me just cover this, and I'll tell you, I mean, when I talk with patients, I go right to it, and I would say 9 times out of 10, they're very comfortable with this. They kind of appreciate a matter-of-fact approach, and we're good to go. So I start out with CPR. I explain that when they're living out in the community, if they have a cardiac arrest, that is heart stops, they stop breathing, they drop down, they die. The only thing that can turn that around is CPR. I explain the odds, depending on what comorbidities they have. It's anywhere from 1 in 20 chance for a relatively young, healthy senior to actually make it, to anywhere from 1 in 50. And so I explain that to them, and then I ask, would they want that? 80% of seniors are going to say, yeah, I would want that. The 20% that say no, I then find out, gee, how strongly do you feel about this? And those that are kind of ambivalent, I don't push the DNR bracelet, but those that say, I feel very strongly, I say, well, that's fine, but do you understand that in the state of Colorado, if you want to make sure that the paramedics don't even initiate this, you need to have either a bracelet or a necklace that says do not resuscitate. Then we go actually a little further because some will say, well, I don't want to wear jewelry. I say, well, that's fine because you don't need to because it's not going to work anyway. So I kind of give them the comfort knowing that, you know, we'll go through this ritual, they won't feel anything, and there it is. But I try and make sure that whether they don't need a DNR order or they do and they need a bracelet, we get that taken care of. Then I move to the second scenario, which is as important because it's, you know, it happens a lot. I said, imagine that you get real short of breath, you're taken to the emergency room. The doctors there find that you have a bad pneumonia and that you probably need to be on a breathing machine in the ICU, giving IV antibiotics, what have you. But that in this case, your chance of recovering is actually pretty good. That is recovering back to your usual state of health. Would you want that? Most seniors are going to say, yeah, go for it. But then when we take it to the next part of that scenario, 2 weeks down the road, everything's falling apart, you have tubes in everywhere, almost all say, no, please don't carry on. So I simply put mechanical ventilation, okay, short term, not long term. If someone makes it clear to me that they don't even want it short term, I then emphasize the importance of making sure family's on board because when, you know, the daughter has to take their mother to the ER and the expectations, we're just going to treat her with morphine to keep her comfortable there. That's hard on families, and they need to be prepared for that. So I separate that from CPR. I go on mechanical ventilation. And then the third is I ask them to imagine, 10 years down the road, they're in a nursing home with an advanced dementia. They can't talk. They can't recognize anyone. They're now getting to the point that they can't swallow safely. The issue that comes up with they want a feeding tube, almost without exception. They'll say, no, thank you very much. The rare ones will say that they would want that based on kind of their faith or religious perspective and what they believe their church or synagogue or whatever might think is necessary. We go into that when that comes up. So when I have those three things there, summarize that, you pretty much have it. Now, going on, there are many helpful tools that can help. I would emphasize this. The advanced directive does not have to be complicated. It can be handwritten. It does not have to be a lawyer-generated document. You can, but you don't want to just stick them in a drawer. Make sure that your family members know where to get them. Though, as I indicate, and sometimes no matter what we have written on paper, it doesn't matter. You have to take some other steps. You do want to have a durable medical power of attorney that designates the medical decision-making agent, and if you can choose one, so that the healthcare team know who they're dealing with, that is ideal. There are other good tools. Living will, I'm not crazy about that in Colorado because the one in Colorado really talks about a condition that's very unusual. You're basically in a, coma, near vegetative state for 7 days or whatever. That's not a scenario that comes up very much. So that one I don't think is very helpful. You have some Cadillac versions out there like the 5 Wishes that really go deep. That's good if the patient and family can take the time to fill that out. There's one called the M.E.S.A form that's well received throughout Colorado, which is just a 2-pager that's can be very helpful. But again, whether you're using one of these well-documented ones or you're just summarizing, as long as your key family members, particularly the medical power of attorney, knows how you feel, that's the key thing.
All right. Last but not least, we're almost out of time. And I just want to slide this in real quick. I think it's incumbent upon us as providers to become familiar with and teach people about hospice services. I think there's a lot of myth and misunderstanding about what hospice is. And so a lot of people think that this is where you go to die. And in reality, we all know that hospice can be on board for many months, and I guess now the criteria can be up to a year or so, depending. And the key issue for me is providing support to the family, as well as obviously pain control. And one of the saddest things that I see on a regular basis is that people wait till the last minute to avail themselves of hospice services. It's sort of like the 11th hour decision when in reality they could have benefited much earlier, and that's just a sad thing for me to see.
Okay, we want to remind you that you can capture the work you're doing. When you're having these good discussions, you can bill for these services based on time. You may have a discussion about advanced directives at the same time you have a discussion about whether it's worth continuing on a stat or whatever. You tie that together, if more than 50% of your encounter is spent on counseling, you can bill for that based on time. We would direct you to our archived webinars where you can learn how to do this.
Okay, that brings us to the end of our presentation for today. I don't see any questions coming up here on the control panel. If you do have a question that you would like to ask after the webinar, you can always go to the website and ask any questions on our discussion forum. We want to just remind you about all the great resources that are available to you and your colleagues in your practice on coloradomesa.org. We do have a new annual wellness visit template up there, which has been generating a lot of interest. So go and check that out if you haven't already seen it. We will be holding our next webinar on Friday, December 2nd at noon, and that will be Dr. Murphy along with geriatrician Clemencia Dublin talking about diagnosing memory loss. So you can sign up for that on our website now, and we will be sending out reminders about that prior to December 2nd. So thanks very much for your participation. We appreciate you being part of the Colorado Mesa community, and we'll see you next time.